This
I
conference
asked,
will now be recorded.
for now, I asked that public comments be submitted electronically ahead of the meeting, and I would normally read one, but we didn't have any comments for this round of meetings, so I don't think there's anything for me to read for the public comment portion. And actually, Les just showed up, so I think we have quorum, so we can go ahead and approve the meeting from last meeting. So I'll go ahead and do that before we forget. So I'm sure everyone had a chance to go over the meeting, the minute from the last meeting. And can I have any discussions, questions, or comments? Okay. If not, then can I have a motion for the record?
I move that we approve the meeting notes.
Okay.
I'll second.
Okay, awesome. Then Steve, yay or nay? Perfect. I don't see Barry. Sterling, yay or nay?
Yes.
Lindsay?
Yay.
Les?
Yes.
Okay,
Yes.
awesome. And Leah? Good morning, Leah. Leah, can you hear me? Okay, it sounds like Leah's having trouble with probably Wi-Fi. But anyway, so I'm going to say yay. Samantha, can I leave out Leah to go on with the approval of the meeting, or do we need to table that?
Hey.
Oh, hi, Leah.
Hi, sorry about that.
That's okay. Sounds like you have a lot on your plate.
Yeah, I'm just
We're
making
asking
coffee.
for the oh, okay. Asking for the vote for the approval of last minute from the last meeting.
Yeah.
Okay, awesome. So it passes. And I think we can go ahead and go on to our next part of our meeting, and which is Amy Hockenberry's presentation regarding COVID.
Thank you. Hello, everyone. Good morning. Happy New Year. I'm Amy Hockenberry. I am the Health Information Assessment Supervisor with the Health Department, and also one of the staff members that's heading up our vaccination planning. So I'm just going to share my screen here. Give me a second. I'm going to be bouncing back and forth a little bit from a couple of screens. So just want to make sure, one, can you all see my screen? Good to go? Okay, great. And I have been asked to present and talk about the inequities that we're seeing with COVID-19, and also the non-infectious health impacts that we've been experiencing, and then also about our equitable vaccination planning efforts. So first, to start off, I want to just talk about the fact that we know that long-standing systemic health issues and social inequities put many people, specifically racial and ethnic minority groups, at an increased risk of getting sick or dying from COVID-19. And this is a lot of what you all already know, but just to revisit, some of these factors that contribute to this risk include discrimination, which includes racism, that can lead to chronic and toxic stress, healthcare access and utilization, which can also be related to other factors like lack of transportation, childcare, the ability to take time off work, communication and language barriers, historical and current discrimination in healthcare systems. I'll just pause a second. I think my cat's yelling at me, so if you hear that, I apologize. Back to the presentation. Occupation. So some minority groups, as you know, are disproportionately represented in essential work settings like healthcare facilities, agricultural, factories, food processing, grocery stores, and public transportation. Another factor is education and income. So people with limited job opportunities as a result of inequities in access to high quality education often have less flexibility to leave jobs that might put them at a higher risk of exposure of COVID-19. And then some people are living in crowded conditions based on economic situations that make it more challenging to follow prevention strategies. And in some cultures, it's really common for family members to live many generations in one household. So you might have seen this on our website. So these inequities and impacts and what puts people at greater risk an exposure of COVID-19, we've definitely certainly seen it at a national level, at a state level, and it certainly has played out here in Whatcom County. So this clearly is looking at our disproportionate impact on our Hispanic and our American Indian and Alaska Native communities. As you can see, Hispanics make up almost 10% of our population, and American Indian and Alaska Native communities making up about 2.5%, yet have proportionally significantly higher rates of COVID as compared to white non-Hispanics. We've also seen this in outbreaks and high rates of ongoing transmission in our agricultural settings or workplaces, industries, food processing, food service, and childcare that our response has been diligently working on all year long. I can say that, right? We're almost at all year long now. Now I want to briefly cover the non-infectious health impacts. So we understand that inequities of social determinants of health, such as poverty and healthcare access, are interrelated, and they negatively impact a wide range of health and quality of life outcomes and risks. So this is included, but definitely not limited to, negative impacts on mental and behavioral health, food and housing security, and economic stability. We've seen these issues intensify with COVID and are impacting populations disproportionately. So data on these issues normally and usually are reported on an annual or every 2-year basis. So there's still a lot of data to understand the impacts of COVID has had on our communities. However, I do have some local data that I can share with you today. And I know that we're also hearing from our community partners about the impacts of COVID that is playing out within our community. So just to give a little glimpse here, for unemployment benefit claims in 2019 for Whatcom County, we had just a little over 10,000. And from January to November of 2020, we had over 53,000. So, and then our highest month was in April, and that was just a little over 15,000. And then for housing, in the last 188 days, there was over 1,400 calls to the 211 support line. And of those calls, the highest need was for housing and shelter, specifically for low-cost housing, rental assistance, and shelters. And then the next highest call, or second to next highest call, was for disaster assistance. And so this is help for preparing for or finding food, shelter, transportation, or health and safety after disaster. And just to give you some comparison, for the same time period in 2019, there was only 832 calls to the line, and there was less than 1% request for disaster. So just to give you a sense of the increase of need that we've been experiencing locally. And then for food security, in 2019, our highest month for SNAP or food assistance program was for 1 month was about 23,700. Every other month in 2019 was below that. And since April of 2020, the number of participants have ranged from 24,600 to 26,200. So this is about looking at 1,000 to 4,000 more people on average a month needing food assistance. And we also know that the WUC, our Unified Command, has been providing a lot of support to the food bank, and we've definitely have seen a high demand all through 2020. I don't have any data, local data, around behavioral and mental health at the local level, but I know that we continue to hear about the rise of depression, anxiety, suicide ideation at the national level. And I was trying to find data, and I did come across a few studies that were published in this last year that were showing depression had tripled in adults during the pandemic. And what we do know is that our marginal and vulnerable populations are more likely to experience all of these health impacts disproportionately. They are health equity issues that our department has always been working on, and we will continue to do so well after the spread of this disease is no longer a threat to our masses. And I think a recent example of this is that has been our support and work with Base Camp and Camp 210. So I think it's a clear example of how our health department, in the midst of working to fight the mitigation of this spread of disease, have been working diligently to support those locations and with testing and provide safe isolation and quarantine facilities for some of our most vulnerable residents. I would like to move on to equitable vaccination system, but I do want to pause here for a moment and just acknowledge and state that what I just covered was merely just a skim of barely a touch of some very, very complex social justice issues in our nation, in our state, and our community. And I'm hoping that I am one of many staff that will be able to come back to this board in the coming months and bring back more data to uncover what is going on, to look at more of the impacts of COVID on non-infectious health issues and how they're playing out, not only to provide more assessment or understanding of how things are unfolding, but also the strategies and the partnerships that we are, community collaborations that we're working on to address these issues. Just with the light of everything that's happening on a national level, I feel like this was, I just feel like I need to acknowledge that this was just a skim, and it's a part of an ongoing discussion that you all as a board have been having. In my introduction, I did say that I was one of the staff members that are heading up our vaccination planning, so I do want to dive into this. First, what I'd like to do first is provide an overview of the different roles, the federal, state, local level, and an overview of the current process. I feel like that's going to help lend itself to an understanding of how we're going to approach equity within vaccinations. And I hope this isn't repetitive of things you already know, and if it is, bear with me. So planning roles for how things are rolling out with vaccination planning is that at the federal level and at the CDC, their real role is around managing the various vaccine candidates, providing guidance on allocation, and then helping and supporting with distribution to the states. That's an oversimplification of what they're doing, but by and large, some of the buckets that at the federal level, their planning roles are. And then at the state level, our Department of Health, they're managing the vaccine provider program. So this is the program that a vaccine administrator needs to enroll into. They are determining provider distribution and supporting transportation of the vaccines throughout the state. They are determining the allocation, prioritization framework, and the sub-prioritization. And they're also in concert with the federal government operating the pharmacy partnership program for our long-term care facilities. And then at the local level, for us with public health, we're providing ongoing communications to medical providers and community partners and to the general public. We're providing support to providers into the state's vaccination program. We're working to understand what our community's capacity is in administering the vaccine. Our role is to really ensure that there's an equitable distribution and the supporting of that long-term care pharmacy program. So I want to cover a little bit of what sort of the process is and how does this play out right now. And I like to describe this from the seat of the administrator, the person who's going to administer a vaccine. And so first, it's a public asset at the federal level, and it's moving from the federal to the state and then down to local providers. And there's many, many guidelines and protocols for the movement before the vaccine actually arrives at a local level. So as an administrator, a potential administrator of the vaccine, there is first the enrollment into the Department of Health program. This takes meeting a lot of the state protocols. It's extensive application with a lot of ongoing reporting. And then once a provider is fully enrolled, they can start in the ordering process, which is right now is on a weekly basis. So they're letting the Department of Health know, yes, we acknowledge that we're fully enrolled, we're ready to receive, this is how many we can receive, this is who we plan to administer or to vaccinate. And then once they are notified that, yep, they're going to receive a vaccine, there's a lot of process and training that has to happen on the provider. As you're probably well aware, there's 2 vaccines that are approved and are being distributed and administered throughout our country, and they both have different protocols, they both have different handling processes, and have different administration protocols. So there's a lot of staff training and preparedness to be able to receive and store and then also administer. And when there are a lot of providers that are receiving the vaccine, first and foremost, they need to vaccinate their staff. So, as you're probably well aware too, both of these vaccines are known to have some sort of side effects that can make people feel not so great and might need a day off to recover before they're back to work. So there's also scheduling of staff and rotations of shifts, so they're not wiping out an entire shift. And then there's actually the administration of this, which we still need to stay socially distanced. And so it's making sure that the spaces they have available can meet social distance protocols and needs, and the ability to monitor people for 15 minutes and be able to medically provide assistance if there is some sort of severe reaction or anaphylactic reaction to a vaccine. So it's just a little overview of sort of like from the feds down to getting it into the people's arms, and all the a very simplistic look at the complexity of what it's taking. I did mention that the Department of Health is responsible and is determining the prioritization and the allocation of who gets the vaccine first. As you also probably heard, the supply is limited, and the supply is limited or being distributed to the states and then therefore down to the local level. So there is some prioritization about who should be getting vaccinated first. So the Department of Health is working with the CDC and other national groups, as well as statewide groups, and soliciting input from locals about this prioritization. And their approach prioritizes populations that have been disproportionately impacted by COVID due to external factors and systemic equities. And they've also taken the fact that we need to protect those that are highest risk of exposure and to maintain a functioning health system. So you'll see that I put a little arrow down at the bottom. It's small print. I don't know if you can see it on your screen. This was just released yesterday. We still are in phase 1A, but the groups for B1 through B4 were just announced yesterday. And it's down on the left-hand corner about the focus on equity. I want to point out that in phase B2, this includes those who are 50 and older and work in certain congregate settings like agricultural, food processing, grocery stores, and childcare. And as I mentioned earlier on, about how we've been watching COVID-19 impact our communities, and these are the very industries that we have seen inequitable impacts on here locally. And then I want to go on to, I know I'm cruising through this pretty fast, but I want to leave room for questions. There's a lot of information coming at you. So as for the health department and what we're doing, we do see that our primary role is to build the community's capacity and infrastructure to support vaccine distribution and administration. We also see our role as supporting the implementation of that equitable framework, and in that, advancing health equity through vaccine planning and administration. Another major role for us is our communications and education. I mentioned that earlier. And then conducting ongoing assessment of vaccine administration. And this will inform our decision making, not only about planning efforts to build further collaboration where needed to fill gaps where they are, but if and when the health department needs to become a provider ourselves to fill a gap if there is inequities. So what's that looking like right now is our current planning efforts are just what I kind of explained. We're convening and enrolling medical providers and pharmacies to assess their capacity, their willingness to vaccinate outside their staff and their patient panels. We're providing technical assistance where we can. And then we're working to connect those those phase 1A groups that are eligible right now to those vaccine administrators so they can start to get vaccinated. And our communications and education, that's a real large heavy lift for us right now. We're providing education and communication to our medical providers, to the general public, and this includes work to identify key individuals who have natural connections to various communities that can help with key messaging and outreach. Developing plans for if and when the health department will become an administrator, again, if there's a capacity need or a gap that we need to fill. And we're also working on volunteer enrollment. We have 250,000 people in our county. Everyone's going to need 2 shots. There's a lot of vaccination that needs to happen. So first and foremost, we're working with our medical providers to figure out what type of mass vaccinations can we collaborate on, and what type of workforce will we need. So we're engaged with our higher ed nursing programs to engage those nursing students as potential workforce. And then we just have many amazing residents who are willing and ready to volunteer. So we're making sure that we can get them registered through the right processes so that when we have mass vaccinations, we have some workforce to pull on. I want to mention, I'll loop back real fast. I meant to mention that DOH, the Department of Health, also is the entity or agency that determines when we move from phase 1A into phase 1B, and they will let us know. And into addressing equity, as you saw in the allocation framework, as we move into phase 1B, and what we've seen a little bit, or we suspect that is when we get to 1C and beyond, this will include more and more essential workers. So we are already planning, and we will be doing more of this outreach and convening of other community organizing agencies like North Sound ACH. They're key to us, the Community to Community Opportunity Council, local coalitions and networks to improve access, break down barriers to access. We'll be working, and we are, to identify, partner, and build relationships with trusted individuals and champions to improve access, and then also to help develop messaging that will reach specific communities. We will also participate with this Department of Health's COVID-19 Vaccine Implementation Collaborative. This is something that DOH just kicked off this week. It's their effort to engage communities and sectors that have been most disproportionately impacted by COVID. They're going to be providing community relations briefings where they can provide vaccine updates, but then they're also going to be holding feedback sessions where members can be invited to provide feedback on vaccination planning and outreach efforts. So again, it just started this week, but we're definitely going to be participating and hopefully engage our broader community into that effort as well. Some other ideas that we've had and we're kicking around right now is to host sort of like sector forums where we can do Q&A, you could call it a town hall per se, and or just community forums so that members can engage with the health department and hear from us or other trusted individuals in our community about how vaccination planning is going, and hear from them. Other ideas are we shared with me with our PIO group is I'm not really well versed in it, but this idea of micro influencers. So these are folks that are like real savvy and like YouTube and I don't know, maybe TikTok or whatever, but where they're using individuals to reach different populations and using these micro influencers and these social media platforms. I know Allison Williams is on here, so she can speak more to that than I can. And then there's King County is working on this idea. I think they're already moving with it though, around census workers. So you know, census was in 2020. They trained up a lot of census workers to go out into communities and engage individuals to be able to complete the census survey. And their idea is to now train them up to do education and outreach around vaccine administration. So we're looking at that as also another avenue. I'm going to stop there. I thought having me talk early in the morning would actually have me talk slower, but that still didn't happen. again, I want to revisit. My heart says I just really want to acknowledge that talking about the social inequities and the impact. I'm gonna cry. It's early. Oh wow, that's emotion. Is big, and there's a lot to unpack there. Okay, so I'm gonna stop. I'm gonna pass it to somebody for questions, and maybe we can talk about some bolts, and I'll settle down. I don't know who I'm supposed to pass to.
Thank you, Amy. That was quite impressive. A lot of information, and I think it's incredibly relevant to what's happening right now. And I'm sure we have lots of questions. So I'm going to leave the floor open for questions and comments.
I have a comment first, and then a question. The comment, I guess, is what a hard winter this is going to be, and how unequal it's going to be experienced. I get the Department of Health's reports on suicide attempts and hospital overdoses and things like that, and we actually trended below 2019 all the way through most of last year until we got to December, when it started to tick up, and we passed it quite strongly at the end of December, where suicide attempts, suicidal ideation that required hospital visits, all of those things are trending up strongly. Kind of like you might expect when a disaster is over and things are supposed to start to get better. So that's my comment. My question is, what are other kind of targets about the number of vaccinations per day that we hope for at the maximum, and where are we in relation to that when we get going?
Amy, do you have an answer to that question?
So there's two questions, right? How many do we expect a day, and then where are we at right now? Yeah. Okay. The first question, I don't know. That will be an evolving number based on the volume that's coming into the community. And so yeah, that's a hard one to nail down right now. As far as where we're at right now, I can tell you that we've had over 5,900 vaccines come into our community, and we don't know the number of how many of those have made it into people's arms, and that's simply because of the data system that we're working with right now. So providers directly report into the Washington State Immunization System, which is the same system they use for other various vaccines. And there's been some glitches, and so right now we're not confident that the reporting for Whatcom County is accurate. So I can't tell you exactly how many have been in there, but we are working with Department of Health, and many LHJs are, to make sure that that data is accurate. So we do plan on providing that information weekly on our website as soon as we can get a regular, accurate cadence with that.
Go ahead, Steve.
This has been really helpful, because I think one of the big questions that I've been running into with people is they didn't know who was in charge of what. And I think that that's something that this offers a lot of clarity, because what I seem to be hearing is that this is very much state provider controlled, whereas the county is working as a facilitator for infrastructure and making sure that things are working correctly and going where they're supposed to be going. Because when I've been talking to people, I think that there's this public perception that there's just piles of vaccines sitting in the Whatcom County Health Department, and I think that good clarity to really help people understand that this is really state provider relationships. But that brings me to my question, which is, how many providers do we now have in Whatcom County? Do we know that?
Yeah, I can answer that one. So we have, actually, let me make sure I'm saying this right. We have 12. We have 7 medical providers and 5 pharmacies that are fully enrolled. And then we have another 32, or is it 35, that are somewhere in the process of being enrolled.
Okay. And
sorry, go ahead. I would just say that the enrollment process is a bit cumbersome right now. DOH is obviously inundated with applications to move people. So it is kind of bottlenecked a little bit.
And then this is just this, you may have actually answered this when Sterling asked that question. But since we're in 1A, do we know what level of coverage our homes have gotten, our long-term care facilities have gotten, since they're kind of the focus of 1A?
Geez, Cindy, you might have the numbers. We have that. We're tracking it. We do know that several long-term care facilities already started getting vaccinated with the federal program that are scheduled. And then we also have some local pharmacies that, just to give you an overview of this, long-term care facilities had the opportunity to enroll. They got partnered up with either Walgreens or CVS, and they're in that process. The goal is to have all in those programs. The goal is to have everybody vaccinated within 2 more weeks, the 3rd week of January. We'll see how that goes. But then there's some either didn't enroll, or when they enroll, there was just it's been a complicated process. Some of them are contracted with local pharmacies, and those are happening as well. And then we're currently actively working on sort of the senior living settings, congregate living settings, as well as home health agencies, and getting them connected with other vaccine administrators.
Great. Thank you so much for this.
There is a website on the health department that actually has comprehensive. It's a file that Greg, Dr. Stern, and a few others have created. So if you want to delve into some details of what Amy was just talking about, there's that available also. Go ahead, Les.
Just as what I've experienced so far, because as a dentist, I guess I qualify as 1A and I can get a vaccine. And the dental world's been talking a lot. We have dentists going to Federal Road to get a vaccine because they can't get it here, supposedly, going to Bellevue, going to Skagit. So whatever we're doing, all I've heard of, I'd be curious to get a list of the 12 that can deliver the vaccine. CMAR and Everson seems to be the only place that is able to get a vaccine into my arm. So somewhere we're missing something.
So first I want to say that, and Erica, you've said it more eloquently than I could probably do right now, but right now we are unable to, for the safety of the sites that are enrolled, there's concern for their safety. So right now we're in a position where we're unable to share the names of the locations. It's up to that individual provider to be sharing out that information. So when we're being contacted, which we're being flooded with questions, as you can imagine, we're not able to just say, yep, go to this one, go to this one. And then, yeah, I hear you on the people needing to go south. I've heard that as well. And it's when the Department of Health is looking at distribution, they're taking a multitude of things into consideration. One is the spread of our phase 1A workers throughout the state. It's the enrolled providers. They also require enrolled providers to submit every week and indicate, yes, I'm willing to take vaccines. This is how many I can take. This is how many people I can vaccinate. This is who I'm willing to vaccinate. So, and this is how much I can store. So there's a lot of things that are coming into place. So some counties are receiving, like it's been different every week about how many are coming into what facilities or providers throughout the state. So yeah, that is what sort of is playing out in the situation about people needing to, the availability might this week be more in the south, and it might be more in a different county next week, just based on how its distribution is going.
Greg, I'm gonna call on Leah first, and then you can speak. Go ahead, Leah.
Good timing. I was going to inquire. I was looking at the 1B populations, and those are a little bit sort of larger and less specific. Are there any disparities data that you are diving into locally to sort of prioritize even more into that population of age 70 and older and people who live in multi-generational families? Or is there any sort of geographical mapping where you're saying, well, more people who look like who represent this demographic of 1B live in this area of the county? Anything like that?
So it just came out yesterday, so we haven't dove into it, and we've done some initial in our interim plan that we have posted on our website. We've done some just sort of not say real quick, but we've done some not prioritization, but mapping or pulling maps to show where different known priority populations live per se at that time. And that was like almost a month ago now. So as far as I will say that we will take a deep dive into where these individuals maybe reside within our communities, and maybe and look at their potential access or lack of access and help address those barriers. But as a health department, we would not be do any further prioritization of those groups to for access, if that makes sense. That is at the state level to do. So if that makes sense.
Yes, it makes sense. I guess it just sort of, from an equity lens, it's just like, there's that population that they've given us, and then diving deeper into that population, looking at where the needs are and where the COVID-19 disease impacts disproportionately.
Yes, and yes to all of that, as far as assessing geographically and or assessing where the potential barriers to access would be, and then help to work with our community partners to remove those barriers.
Yes.
Go ahead, Greg.
Yeah, thanks. I just wanted to frame some of this to point out that this system of delivering vaccine is being designed as the vaccine is being rolled out. And there's some really specific details as the FDA authorizes emergency use, the storage, the administration issues. So I guess what I'm asking is that there's some patients that, we have not had allocated enough vaccine yet to cover all of the 1A eligible folks in the county. And given the system was designed that for the vaccine to be shipped directly to the administrators, to the clinics and pharmacies. It's not like there's a warehouse at DOH at the state where the vaccine goes and then they ship it out. This is a system where they determine they hear from the feds how many doses will be allocated. They divide it up, and then they provide information where the distributors will send the vaccine. The vaccine program enrollees that are saying we would like 1,000 doses next week, they are given either maybe what they ask, maybe a portion of it. It's very difficult to schedule a vaccine. So there's some very complex details about moving vaccine quickly from an allocation to what you actually receive, to have things scheduled so that people can get it in their arms. And we're also left with this system of pharmacies and clinics administering vaccine to folks. The issue of having unaffiliated folks, people that aren't affiliated with their practice, either as staff or within their patient panel, how do they turn into change their operations to provide vaccine to folks that aren't affiliated with their practice? These things are being deliberated now. Some of our partners have worked out ways to do it, but so Les, when you were talking about having to go down to King County to get vaccine for dentists, part of it is that some places have worked out those systems, but we're almost having to invent it locally, and for each practice has its own unique relationships with that. So it is happening, and within we anticipated improving. But again, we're like, where are we? Week 4 of this distribution, and we're finding a lot of unanticipated or dilemmas in actually implementing this process. But we are working closely with our partners. We're trying to collect as much information as we can with a data system that's not very transparent to us either. So.
Okay, Steve, just make it a real quick because we're like really squeezing out of time. Go ahead.
Yeah, I just wanted to add that I think that kind of what's being said here is a really important communication point just for the public. There's mass confusion because at a national level, every state is doing this completely differently. And so people are like, well, my cousin got vaccinated in Texas just by waiting in line at a Walgreens. So why can't I just go do it? And so I think that, there's a lot of confusion as to like what's happening here because people are watching what's happening somewhere else. And so I think that how our system is set up and the way things are functioning here, really basic, dry information, but I think it's really pertinent information for our population to hear and to understand because they're just looking at national media reports a lot, I think.
Just kind of answer to that question or that issue, Steve, of communication. On the health department website, there really is a wealth of information. It may not answer, all, but there's a lot of information that they can extract that's already on there. And like any other events, communication is always the first to break down. And right now, kind of what I say is that there's a national delay in this rollout of vaccines. And it's frustrating because every state is doing it differently and there's no cohesive plan. But the one thing that I think that I see is this is something that we've never done before. So it's very glitchy right now. But as we do it for more and more, it's going to get better. And, it will take an asymptotic slope of, it'll get better much faster as we continue doing this. So by the time we get to the mass vaccination point, I am positive that our county will be doing our job with expected speed. My only question, and I don't only think that we have time for this discussion right now, is the criteria that the DOH is looking for in order for Whatcom County to move to the next phase. I think for me that's kind of the question, so that we can move forward. But that question I can talk to Greg or Erica at another time. But again, there's a lot of information on our website, health department website. So if you guys you guys are the spokesperson and with a lot of influence and people looking up to you as leaders. So when people ask that question, say, I'll either find out, I'll talk to somebody, but please go to the website and give them that information so they are empowered as well. So I know we want to talk about this more because this is so important. And it is all on our minds. But are you guys okay if we move on to the next item, which is the Racial Equity Action Plan with Astrid? Are you guys okay with that? Go ahead, Eric.
And I'll be very brief. I know we're running late on time. There is a lot happening right now with the new Safe Start, re-envision the roadmap to recovery as a regional, with vaccine planning, and I think what I'm hearing from you all is there's a real interest and desire as our advisory board to have more information, and we'll make sure that we communicate more regularly with you about what's happening as well. So you can also help us share messages and push that out to the community. So I'm definitely hearing that. And I also just want to acknowledge and thank our incredible team, Amy and the other staff that have been working on the vaccine planning. It is the sort of, this is the project that we have been building toward through this entire COVID process. And it is by far the most complicated, the most political, the most challenging, and the most urgent of all of the challenges we faced in COVID. Everything we've been doing is like training for trying to get to vaccine. And Amy and the team have been doing incredible work. So I just want to publicly say thank you to the team that's working on this.
Totally agree. Thank you. Amy, just off to the side, you guys, you were talking about possible connecting with influencers. My son has 1.5 million followers, so if you want to talk to my son about that, let me know. And
Allison, will you hear
I'm sorry, what's that?
Allison, will you? I'll just actually, well, Allison's going to mark that down.
Okay. Okay. I figure instead of him doing silly dances, he can do this and actually be productive and give something positive back to the community. Okay, so Astrid, are you ready to talk about the Racial Equity and Action Plan?
Yeah, and I'll just kind of condense it a little. I know we've got a number of other topics just to get through, so I will condense this a little. Let me just share my screen and then make my. Let's see. It's so hard on this. Okay, hold on. Can you see my screen or not yet?
Astrid, I thought someone asked, I thought John asked me to make him presenter. Are you presenter? Maybe that I need.
Well, let me.
Yeah, that's only because I hit the wrong button and Samantha took care of that for me, I thought.
Oh, okay. So maybe power is off my hands.
Okay, let's see. I'm going to share this and then go from the beginning. Okay, are we good? Yes, okay. Thank you so much. I am Astrid Newell, the Community Health Manager for the Whatcom County Health Department. And the purpose of this topic is to follow up on the Racism as a Public Health Crisis resolution that the Public Health Advisory Board championed through its passage in November of 2020. And just the idea here is just to talk through a little bit about the follow-up role, Public Health Advisory Board's role in supporting the Health Board and the Health Department in their action on this issue, and consider steps that the Public Health Advisory Board wants to take to advance this, not only on the kind of county level, the Health Department level, but within the policies and practices of the Public Health Advisory Board. You know, how can we advance the spirit of the resolution within PHEB? And then if there is an action item that we could take in terms of the Public Health Advisory Board, creating a subgroup to 5 minutes to talk about this is not enough. And I think that's about what we have this morning to just follow up on this issue. So I would recommend that the group talk about a strategy for a smaller group to get together to kind of plot the next steps. Just for the sake of the audience, in the packet there is a brief PowerPoint presentation, just highlights of the resolution.
I think we lost Astrid.
Yes, it looks that way.
Samantha, can we get back to her somehow, or does she need to just come back herself?
Unfortunately, she needs to log back in herself because she completely exited the room.
Okay. All right. For the sake of time, Judy, do you want to just pick up and then when you're done, Astrid can continue? Are you okay with that?
Yes, absolutely. Good morning, Judy Zales. I'm a public health nurse supervisor for our child and family health programs, and just giving you a brief update on our child and family well-being task force, and queue you up to identify a representative to participate. So I think you can see my screen at this point. Excellent. So just as a reminder, the ordinance did pass in December. Thank you to all of you for your work and persistence in elevating the importance of young children and families during this really groundbreaking time that we're having. The initial phase identifies work that needs to be done by the task force and queuing people up as far as getting going from the beginning. And the first piece is really to ensure that the work is grounded in equity, family engagement, and results-based approaches. And then additional tasks that are identified in this phase one. So that's what the group that will be brought together will be looking at initially. In the ordinance, you might recall that there are 3 phases of work that are spelled out. And I see that the work will be they won't be a phase that will be completed all at once and then move to the next phase. There will be pieces of work that take longer and can pick up additional phase 2 work. And in part because of what is going on in the current landscape. So as you know, the task force is not operating in isolation. There's a lot of interest and work that's happening in the young children and families arena, much of which you're familiar with. Many of you are participating in some. A group of people recently attended the Children's Funding Institute. There is interest in our community to identify a pathway to establish additional funding mechanisms for young children and families. Generations Forward Policy Advocacy and Funding Group is doing work to develop a communications plan to really build up an understanding and interest in the importance of young children and families. There's child care expansion work being done by a lot of entities, ongoing community health improvement work, and then existing coalitions. So the task force really is concentrating on the role of county government, but it needs to have a level of awareness of what's going on in the community and work in conjunction with what's happening in the community. Just for the onset, the ordinance did pass in December, and we started recruiting in December for members. At this point, we're continuing recruiting, and our small team that includes M. Biganjari and Allison Williams and myself, we're starting to develop the initial framework by putting together a member learning agenda based on the initial tasks, and also focusing on that groundwork that needs to happen, and meeting protocols, identifying a facilitator and such. And we'll look to begin convening in February. Initially, plan to convene twice a month in order to really get through our norming and storming and groundwork. And eventually we'll probably back off from that, but it will initially be a pretty intense schedule, and the first progress report is due to the County Council in June. Based on the ordinance, our recruitment objectives are focused on the appointed members. As you may recall, there are 15 representatives, one of which will come from the Public Health Advisory Board, and 15 appointed members based on experiences that you and the County Council identified as important, and really in this recruitment process wanting to blend that lived experience with the skills and knowledge needed to complete the identified tasks. During our recruitment, we've used our contacts that we already have, as well as community organizations and membership groups that are affiliated with particular parts of our community, and we have translated our recruitment materials, are using trusted messengers to spread the word. And I think in grounding in equity and family engagement, we're really hoping for increased diversity on this membership, and working with the county system on developing stipends as a pilot for this task force, and that's something that isn't currently done. So developing what is the administrative process to make that happen. We have encountered feedback that the requirement for all task force committees and boards county government that members be a U.S. citizen and be registered to vote is problematic in recruiting some segments of our population. So working through those challenges as well. And then the representative members are identifying just key contacts, and that is requesting a given board or organization or community group or local government or tribal nation to identify a representative to participate, which I think we're heading to here for the Public Health Advisory Board representative to be identified as well.
Thank you, Judy. That was mighty quick, much quicker than I thought you were going to be able to do the presentation. But when we're talking about shortened time span, I guess that's what we have to do. So do you guys have questions and feedbacks for Judy and what she just presented? Go ahead, Sterling.
Yeah, this is going to be, as we learn more about the wreckage that COVID is going to leave behind and the inequities that it's causing. Families are going to be the ones that are most affected, as always. And this idea that we could put children and families first is a really important piece of how we respond to this disaster and what we're going to do to really help those who have been affected the most.
Any other questions or comments? Go ahead, Steve.
I just wanted to point out that I had no idea that you had to be a U.S. citizen and registered to vote to participate in our task forces. And considering the work that we do, that seems, for lack of a better phrase, absurd. If we're trying to engage communities and involve communities, that seems a strange barrier to place in front of people. That's it.
I don't know, Judy, is that a state law or is that something that was placed by our county council? Where does that rule come from?
It is in our county. It is in our county code, and I don't know. I don't know if it is if there's something that at the state level in the Washington Administrative Code that indicates that. But it's certainly. I think you've done a really nice job setting this task force up to as one of the tasks is to identify how to diversify membership in all county boards, task force, and committees. And so going through this experience and wanting to recruit diversity and recognizing those barriers will help queue up this task force to be able to point out what are those elements and what can be changed at the county level.
And do we think that that would be able to move fast enough in order to have people who are applying at the end of January be considered, or is this something that will, okay.
So then do we have a plan to how to overcome that? Or there's just no way to overcome that specific rule?
For this initial round of recruitment, I mean, as applications are due January 19th, there's not a path forward, but it is on the agenda for the task force. Like, okay, so here, if we want to diversify membership for this task force and other involvement in county government, what are the barriers? And this is certainly one of them. And, okay. And then how do we address it?
Okay, go ahead, Steve.
I think that there might be opportunity within the racism resolution and some of the stuff that will come out of that as well.
Yeah. So it seems like we're going to have to kind of work in conjunction simultaneously to overcome this while we're working on this issue. Very tricky. The second part of the question that Judy brought up is identify PHEB representative to the task force. I have Sterling Chick's name. Is there anyone else who might be interested to be a rep? Okay, so then are we okay putting Sterling's name forward to be part of the rep? Okay. Lindsay, are you okay with that? Les, are you okay with that? Okay. Leah, where's Leah?
I'm okay with
Okay,
that.
I'm not seeing. Okay, awesome, great, thank you. So did we address both of your questions that or things that you had put forth to PHEB to discuss? Judy, are you satisfied with what we have so far? Okay, perfect. Okay, so Astrid is back. Yay, thank you. Thank you for logging back because I didn't know how we were going to find you back to log back to us. But no, it's it's technology. I'm trying to figure out where we were when we lost you. I think you were kind of at the community action, sort of in that area. Okay. So you were pretty close to the beginning if you want to pick up where you left off.
I think for the benefit of time, that the main purpose today is just to get a sense from PHEB what role you want to take in moving some of this work forward. There is work that needs to happen kind of within the county, and I know Erica has set up some an opportunity to meet with Stat Paul to talk and our HR folks to talk internally about some steps moving forward and how our county executive wants to support this work moving forward. So I guess part of the discussion today for PHEB is really what role PHEB wants to take, and are there opportunities within these meetings, within the Public Health Advisory Board structure, to take the spirit of the racism as a public health crisis resolution and really think about your own meeting structures, your own training, and opportunities to really embed racism and anti-racism into the work that you're doing. The topic that Amy presented this morning around the equity and vaccines and equity in general around COVID, that's the kind of approach that could be taken within PHEB, but that's really up to you to decide what steps you want to take as PHEB to move this work forward. There are some in the packet and the information. A suggestion or an idea would be to have a smaller group of PHEB to talk through this more specifically. There's some wonderful tools through the Government Alliance on Race and Equity that can be used and reviewed, and great frameworks that can support this work. And then there's also a lot of work that's happening in the community and interest on moving forward with a racial equity commission, and the Public Health Advisory may want to know more about that. I see Amy Rydell is on the call here. And so there are a number of different opportunities to move forward. But I guess I wanted to just keep this. We wanted to keep this issue in your view, and make sure that this moves forward with the urgency that it deserves.
Again, that was a really quick, condensed version of your presentation. But I think the important points or the questions that we need to answer as a board is, number one, do we want to create a subcommittee? Can I see raise of hands to see if that's what we need to do or would like to do as a PHEB, as a board? Okay. I think, okay, so let's, so Samantha, is that something that we need to create right now, or can we do that via email after the meeting?
That is a very good question. I'm fairly certain that we could do it via email, but it would still need to be brought back to the board to actually be officially voted on, though.
Okay, so then let's vote on that. So do I need to, so Samantha, do I need to have the members for subcommittee right now if we are to vote on that right now?
Yes, I think that would be accurate.
Okay. Okay, so I think we need to vote on creating a subcommittee for the racial equity action plan subcommittee. And I saw hands for Steve, Les, and not Leah, Lindsay. And so can I have you three create the subcommittee?
Can I just confirm that this is in the agenda? It says that this is to review the GARE resources and recommend processes, or is this a different, are you, Gina?
Well, the subcommittee will definitely work on the GARE as well as other processes that's associated with this whole work. So it's a subcommittee that will be dealing with the racial equity action plan, but it will be working on the GARE.
Yeah,
Sorry,
I guess I just wanted to clarify that there's when we talk about a racial equity plan, there are many things happening currently. The community, there may be a racial equity plan that's more of a community plan, and so there's work that's happening in that avenue. I think for PHEB, it's really about identifying what action plan you all want to take to move this work forward and what your role is. So it's not necessarily you needing to create the action plan for the community. It's about what role PHEB can have in your own action, as well as supporting the work of the health board, the county, the health department. So just wanted to clarify that the term racial equity plan will mean a lot to different people. So just to clarify that that's the intent here.
Right, the subcommittee. Go ahead, Steve. Go ahead,
and
Steve.
we're looking specifically at the outcomes of the resolution and the way that PHEB can support the outcomes of the resolution.
Right.
Of which GARE is just one.
Right. GARE is just part of that whole thing. Leah, I'm not seeing you, so I can't see if you are interested in being part of the subcommittee.
I am. I thought our first vote was to create the subcommittee, and then
Yes.
I was going to chime in.
Yes.
Okay.
Okay. So can I have a motion to create the subcommittee?
I move to create the subcommittee.
Can I have a second?
I second.
Okay, awesome. Okay, Steve, yay or nay?
Yay.
Sterling?
Yay.
Lindsay?
Yay.
Les?
Yay.
Leah?
Yay.
Okay, so it passes unanimously. So then can I see a show of hands to be a member within that subcommittee? Okay, Lindsay, Steve, Leah, Steve. Okay, so I have Steve Bennett, I have Leah Wayman, and I have Lindsay Karras to be. Sterling, did you also raise your hand too? No. Okay. So so those three will be the subcommittee for the Racial Equity Action Plan. So the second part of the question that Astrid was asking was the kind of the board training as PHEB, and I don't actually really know how that would entail, because a lot of the training had already taken place last year. I'm not quite sure what we can offer for board training. Astrid, is kind of what I'm getting at. Is there anything else that we can offer?
I would suggest that the subcommittee also include that in terms of discussion of what might be helpful. I mean, I think there has been some broad community training, but that I'm not sure that everyone on PHEB has had the opportunity to participate in those trainings. And so, so I think there would be a great opportunity for that subcommittee to talk about the specifics around PHEB and what recommendations to make for trainings and as well as change in process and
Perfect. I love that idea. And then I think the other part of what the subcommittee needs to work on is the membership recruitment. And I know we've been lacking representation from the tribal community, and I think what we have done so far is we sent a letter out to Barbara Juarez saying that she is still on the board, and we welcome her presence back anytime she's able to. And in addition, because we need a voice, especially in light of the work that we're doing currently, we need a voice from the tribal community more than ever. So we are actively looking right now. And I know we've had some couple of names, but it hasn't followed through. We don't have anybody that has definitely applied. So continue looking. We're actively recruiting right now. But if you guys know anybody, please encourage to apply. Application is pretty simple online, and it's attached to our website as well as the health department website as well. Okay, so is there anything else that we need to discuss with the Racial Equity Action Plan? Are you happy with everything that we have discussed? Is there anything else, Astrid, that you can think of? Okay, perfect. So then the next item is chair and vice chair election. So the first thing that I just want to quickly go over is I don't know if Lindsay, if you reapplied, but please do so if you haven't. And we have 2 additional applications. And so I think Sterling and I will talk after with Erica and Samantha, or did you want Kathleen to do that? I think Kathleen has that responsibility to interview the applications with us. And so we'll arrange times to go over and interview those 2 additional applications. And Samantha, I don't know if I'm remembering this correctly, but April Barker, I believe, had asked in the midst of COVID, like last March. But I cannot find her application, and I wonder if we can look at her application as well. And we've interviewed Jacob Anderson in December, and I don't see Kathleen. But Sterling, oh, there you go. Hi, Kathleen. I'm totally blind. I think the 3 of us felt like he was a good fit. So it's just his application is just at a point of going through the vetting process through the council and the exec office to be approved. And he probably would be joining PHEB. The first meeting would be in March. Okay, so then the next question is voting for chair and vice chair. So I have Sterling Chick, his name put forth for chair. And since he's been vice chair, I think that's sort of kind of been traditional. But if anyone else is interested, please let me know. I don't want to just have sort of monopolized the position, but anyone else interested? Okay. All right. Sounds good. Then I do think that we need to have a vote for Sterling to take over as the chair. And so can I have a motion? I can motion. I'll motion. Can I have a second?
Second.
I second.
Okay, perfect. Thank you. Okay, so then let's vote. Steve Bennett. Yay or nay? Okay, awesome.
Sorry.
Sterling? That's okay. Sterling?
Do I vote on myself? That's weird.
I don't know. That's kind of crazy, right?
Am I volunteering to do this? Yeah, I am.
Okay. How about you, Lindsay?
Yay.
Okay. Les?
Yes.
Leah?
Yay.
Okay. And I also say yes. So he passes unanimously. And I also now to vice chair have Steve Bennett's name. And Steve, the last email I got was that you have not reapplied, so please reapply in order to
Yes,
take
I
the
just talked to
position.
Samantha about it. It's
Okay.
coming to her at the moment.
Awesome. Okay, awesome. So do we have any other name for vice chairs? Okay. So then I guess we're just going to vote Steve in as vice chair. So I'll motion for Steve Bennett to be vice. Can I have a second?
I second.
Second.
Okay, awesome. So then let's vote. Steve Bennett. Yay or nay?
Yay.
Okay. Sterling Chick.
Yay.
Lindsay Karras.
Yay.
Les Seeley. Or Dr. Seeley.
Yes.
Leah Wayman.
Yay.
Okay, awesome. Also passes unanimously. You guys are just too agreeable. There hasn't been too many discussions about this. Okay, so we now have Sterling as chair and Sterling Chick as chair, and vice will be Steve Bennett. So that ends the election, and I have to say,
Can I
go
say
ahead.
something?
Go ahead. Sure.
The reason that this is happening, Gina, is that you're leaving, right? Are you going to announce that, or am I,
Well, I assumed it was kind of implied.
and I wanted to say something about that, if you don't mind.
No, go ahead.
I just want to say, you've had this amazing commitment to public health that you've shown by the years of work that you've put in PHEB. There's a lot of work in this committee. We don't get paid for it, and you've done an amazing job. And I've had a chance to be around how tenacious you are and how knowledgeable you are, and mostly a chance as vice chair for a year to get a chance to soak up some of your wisdom. And I don't know if that's going to stay, but I just how you run meetings and how you kind of get to the gist of things is amazing, and I so much appreciate again your wisdom and your heart and your commitment, and I wanted to thank you for that.
Oh, thank you. Thank you. Hi, Erica. Go ahead.
I want to add to that, Gina. You have been one of my most trusted advisors during one of the most challenging years we've had, and you have led not just the PHEB but the community in the way you have shared information with our health board, with the public, the way you had vision in developing partnerships and leadership with our business and nonprofit community. There are so many accomplishments, and I know that when I was assistant director before I left and came back, you were involved in so many different things, and I know Astrid can add to that as well. But last year was a really challenging year for public health, and you were our leader, and you were such an incredible partner, and I'm really going to miss you, both personally and professionally.
Thank you. Well, Erica, just so you know, I'm still working for the health department, so I'm not really going away.
We're so grateful for that too.
Well, thank you so much. Thank you. Go ahead, Leah.
I feel like we've met in person once.
But I just want to say I really appreciate your just sort of bringing me into the fold of this group, and coming in and having sort of my second meeting be a virtual meeting, and all this year be a virtual meeting, and your continued sort of encouragement and your gentle probing to bring me into the fold and to sort of elevate my voice. And I really appreciate that. And I think that is a skill, that is a leadership skill that is greatly valued and doesn't exist everywhere, but I see that in you and I really appreciate that.
Well, thank you. Thank you. Go ahead, Astrid.
We're all kind of waving our hands. I wanted just to say, so Sheena, you and I got to meet before you became a member of the Public Health Advisory Board. I remember having coffee with you. You were interested in exploring a role in public health, and we had coffee, and you talked about your background and your interest. We bonded on both our love and our passion for children and families. Yeah. And I have just so over these years, I've just so appreciated you as a partner, and just thank you for your leadership of PHEB, as well as your work around children and families. You've been deeply involved in all the many things we've been trying to do as a community. So thank you.
Oh, thank you, Astrid. Well, thank you, everyone. I'm going to start crying. Oh, Steve, go ahead.
It's like, come on. I just to echo what everyone else has already said, and to thank you so much for your leadership and guidance, and for being in that role in this year, especially beyond COVID, even many of the other things that we have gone through this year. Thank you for dealing with me when I call you in emotional spirals and responses to various things. And talking me off the edge, and being able to talk through things. And so bravo for the work that you've done, and thank you. And as you mentioned, you'll still be at the health department, so you will probably still be calling you.
Absolutely. And like all of you guys, feel free to call me anytime. I think all of you guys have my cell phone number. Call me anytime. But just parting words, I have enjoyed working with every single one of you. And I think every single one of you, just not just the board, but Astrid and Judy and Kathleen and Erica and Amy, all the Amy's. Incredible. You guys are just incredible. And the work you're doing is unthanked is not really a word. Unappreciated is not really the word I'm looking for, but it's thankless job that you guys just continue day after day. And when you can do that kind of work, it comes from the core heart inside of you that keeps you going, motivated to do the right thing, not just for yourself, but for the greater community and the future generation. So bravo to all of you. It's been great. Like I said, I'm here. I'm not really going anywhere. So you guys feel free to call me anytime. And I'm going to say this to the ladies. We're working on diversity. Okay. We have chair and vice chair, both males. And I love that. You guys are awesome. We need female voices in there, so don't back down. You guys, Steve and Sterling need you guys more than ever. This is the time to shine together. And I have faith in all of you guys. Okay, so with that, I'm going to actually end the meeting 4 minutes early. Okay, meeting is adjourned. Thanks, everyone.
Thank you.